We will have the talks from 4 researchers, 4 specialists from the international community, and they will each be about 15 minutes. At the end of the talks, we will have an opportunity to discuss and have a little open. If you have any questions, you can use the Q&A function, which should be at the bottom right of your screen, and I will read your questions, and hopefully we can answer them. I will leave the word to my dearest colleague, who is Dr. Matteo Bonarroti. He is also a medical doctor, and he's a licensed. He is also training in psychiatry, and he works in the city of Viterbo, where he has a public outpatient psychiatry clinic, not has, but works there. And he is also the co-founder and vice president of the first Society for the Study of Psychedelic Medicine in Italy called SIMEPSI. Additionally, he is also a licensed psychedelic psychotherapist and practitioner. Hello, Matteo.
Hello, Georgia, and hello, everyone. It's a real pleasure for me to open this webinar because today we are addressing a challenging hot topic that sits at the intersection of 2 complex and evolving areas of clinical research. And for SIMEPSI, our organization, exploring this liminal boundary isn't just a theoretical exercise. Instead, we see it as an urgent and necessary step toward responsibly integrated psychedelic treatments into public mental health care systems in the near future. Our approach draws inspiration from the legacy of Franco Basaglia, who revolutionized psychiatry by focusing mental health care on dignity, inclusion, and recognizing the full social and clinical complexity of severe mental illness. Additionally, Italy has a unique and often overlooked history of psychedelic research, particularly regarding schizophrenia and other psychotic disorders, with pioneering studies dating back to the 60s. Therefore, we are excited to bring this topic back onto the international stage, aiming to foster reflections and move beyond taboos and prejudices. Now, psychosis remains one of the most complex and unserved areas of psychiatry, profoundly impacting patients, families, and entire communities. At the same time, psychedelic-assisted therapies are emerging as potentially transformative innovations that are reshaping our understanding and treatment of mental health conditions. But currently, clinical trials in the psychedelic field usually exclude individuals with psychotic symptoms or those with a family history of psychosis. While this is probably understandable, it leaves crucial questions unanswered, such as, should we maintain this exclusion in the real-world practice, or is it time to challenge this assumption? Could specific subtypes of psychosis benefit from these treatments or not? Could careful, controlled clinical settings, skills, therapeutic support, and an appropriate pharmacological support help mitigate potential risk of these interventions and unlock new therapeutic possibilities for people experiencing psychotic symptoms or disorders? Furthermore, we can't ignore the broader reality of psychopharmacology, because historically we know once new treatments are approved and enter widespread clinical use, the criteria for who can or can't receive treatments inevitably expand. Because of this, it's essential we proactively, while carefully, start investigating now how psychedelic compounds would affect individuals who have psychotic vulnerabilities. We must understand the safeties of these therapies, but also their potential effectiveness in several psychopathological dimensions that are characteristics of severe mental illness, such as negative symptoms, for instance, that current treatments frequently fail to address adequately, especially in people affected by psychotic disorders. These aren't hypothetical questions. They're practical and pressing considerations for the real-world implementation of psychedelic therapies. And these questions drive the work of our international research group that is dedicated to rigorously and ethically exploring the potential role that psychedelic therapies could play in this complex and delicate field. We warmly invite you all to join this conversation, share your insights, and consider supporting our research project by contacting us at beyond@cmepsi.it. Together, we aim to go beyond current paradigms in both psychiatric and psychedelic care by breaking barriers, expanding knowledge, yielding new insights, overcoming stigma, navigating complexity, and driving innovation. Enjoy the webinar.
Thank you so much, Matteo, for your introduction. And before we begin, I would like to thank and express our deep gratitude to the academic and institutional partners who supported this event, particularly the University of Geneva, the San Raffaele University of Milan, the Italian Psychiatry Society, the Psychedelic Access and Research European Alliance, PAREA, and the International College of Neuropsychopharmacology. Regarding the latter, I would like to remind everyone that there are 2 annual meetings we advocate for and would be lovely to see you there. The first is on the 15th to the 18th June 2025 in Melbourne. It's a bit far from Rome, but I'd really love to go. And then there will be another one next year between the 26th and the 29th of June in Glasgow. Oh, that's a bit closer. So I'm going to now present our first speaker, who is Michel Sabet. I hope I said that correctly. And he is a psychiatrist at the Geneva University Hospital. He has been working on several years on the treatment of the negative symptoms of schizophrenia and evidence-based medicine. And more recently, he has been focusing on psychedelic-assisted therapies. And his talk is about reconsidering evidence for psychedelic-induced psychosis. Thank you very much.
Greeting everyone. So I'm just going to load up my PowerPoint. I think you can now all see my presentation. Voila. So yeah, I'm a psychiatrist at the University Geneva, the Geneva University Hospital, and my research focused mainly on treatment options for negative symptoms of schizophrenia. And recently, I had an emphasis on the potential role of psychedelics. So in this first presentation, I will discuss one of our latest article from our research group entitled Reconsidering Evidence for Psychedelic-Induced Psychosis. So I declare I have no conflict of interest related to this presentation. So as you all know, traditionally, certain patient populations have not been considered in psychedelic treatment approaches, including individuals with schizophrenia spectrum disorders and bipolar disorders. Yuri and colleagues in a recent paper found 26% transition rate to psychosis among hallucinogen users and non-medical settings. This rate, however, is lower than the one associated with cannabis, which is of more than 30%, but at the same time, higher than the rate for amphetamine of around 20%. However, these findings are based on the paper of Yuri and colleagues, only 3 studies, with one study contributing significantly to the data, particularly regarding phencyclidine users. Phencyclidine, which is an old drug that we don't really see today, but which is really prone and provoking psychotic state in users. More recently, Tori and colleague in 2024 have also published very interesting subjective reports on the use of psychedelics in this specific population. So one open question remains: could psychedelic drugs play a role in treating schizophrenia? So to start exploring this question, we conducted a systematic review and meta-analysis to take a first fresh look at the current evidence surrounding psychedelic-induced psychosis. So you can find our paper, which has been published in December, if I'm right, which is open access and molecular psychiatry. So, in this systematic review, we included more than 100 publications, which covered a range of study types: systematic review, randomized controlled trials, case control studies, uncontrolled trials, cohort studies. So different type of studies, which unfortunately were, for most of the studies, of low quality. However, we managed to re-examine the evidence and the prevalence of psychedelic-induced psychosis in a different type of population. So in the general population, we only have a prevalence of psychedelic-induced psychosis of 0.002%. And in controlled trials that exclude patients with psychosis, we have 0.2%. We have 0.6% in randomized controlled trials that also exclude a priori patients with psychosis. So it was mainly studies on patients having been diagnosed with depression. And we found in uncontrolled trials that included stable patients with schizophrenia who were not taking any medication, a rate of 4% of risk of psychedelic-induced psychosis after mainly LSD use. Additionally, however, we also find a 30% prevalence, which is lower than the one found by Murray and colleague, of patients who experience psychedelic-induced psychosis and unfortunately who later develop schizophrenia. So to sum up, schizophrenia might not necessarily be an absolute exclusion criterion for clinical trials investigating the safety and effectiveness of psychedelics, especially when it comes to the treatment of patients presenting treatment-resistant depression associated to schizophrenia or, of course, negative symptoms. However, well, caution is still important, particularly for patients who are clinically high risk for psychosis, and especially patients who are in so-called transitioning phases. So it's the patient that presented side effects following substance use, in particular psychotic side effects. So psychedelics for negative symptoms. Could psychedelics be an option to address negative symptoms? This idea has actually been explored before, particularly in population who were diagnosed with schizophrenia and who were not taking any medication. Why? Because most of these studies has been conducted more than half a century ago. So we don't have time to go through all these studies presented in our paper, and here I only show 3 of these studies. But to summarize, even in population with schizophrenia spectrum disorder, also back then the diagnosis of schizophrenia was sometimes, let's say, a bit messy. Treatment with LSD has been attempted. Most of the patients show little response to the drug at usual dose without taking any medication again, and less than 5% of patients showed significant worsening of their condition. So this suggests that LSD is relatively safe in this context. In fact, some patients even showed improvement in their mood. However, it's important to note that, again, the quality of these studies is generally quite low. So what about MDMA for negative symptoms? So, as you know, MDMA is classified as an adaptogen. MDMA is known to increase sociality and enhance personal relationship and feeling of closeness. It also targets social functioning and reward processing, which are often impaired in schizophrenia. In animal studies, MDMA has been found to induce metaplasticity in the nucleus accumbens, So this means it can really reopen a critical period for social reward learning and can promote the formation of new synaptic connections. And things are moving forward, as you can see, with currently MDMA being evaluated for the treatment of negative symptoms in schizophrenia in the US, and an open level ascending dose within subject trial. So in this study, participants who are diagnosed with schizophrenia and who have ongoing medication will receive doses of 40 milligram, 80 milligram, or 120 milligram of MDMA. So I had the opportunity to talk with one of the authors of this study, and the first aim is really to assess tolerance of MDMA in the population. However, as a secondary objective, they're also gonna try to find if there is an effectiveness on a particular social connection. Now, what about psilocybin, which is more of a focus here in Geneva? So psilocybin is like a classical psychedelic. There is growing evidence showing that it can enhance emotional processing and offer therapeutic benefits for conditions like depression, anxiety, and PTSD. Psilocybin has also the potential to reduce social withdrawal, also to improve emotional insight and reframe negative thoughts patterns. And it can also lead to significant shift in self-awareness and emotional state, as well as improve brain function and connectivity. So this is hot on the plate. We're just moving forward with psilocybin. As one of our case reports we conducted here in Geneva has just been accepted by the Journal of Psychiatry and Neuroscience. So in this case report, it involved a patient with a schizoaffective disorder who was stabilized and who presented treatment-resistant depression and predominant negative symptoms. And I really insist on the predominant negative symptoms, which was quite striking in this patient. So this patient was stabilized with amisulpride 400 milligram, a D2 blocker. So amisulpride is a kind of spatial antipsychotic because we mostly find it here in Europe, but less in the US. Basically, it acts a bit like alloperidol, Aldol. It's really a D2 blocker, and it doesn't really interact with serotonin receptors. So for this patient, after a 20 milligram session of psilocybin, the patient had a 5-hour psychedelic-assisted therapy. He experienced an immediate reduction in depressive symptoms and as well as secondary negative symptoms, and he really benefited from this psychedelic trip and the psilocybin. And importantly, I still follow up this patient. He's gonna now try a second session with LSD this time, and to date, he still have improvement on the long term from this first initial session, which was more than a year ago. Internationally, people also go forward with psilocybin therapy. For instance, here for mood dysfunction and Parkinson's disease, which has been recently explored in an open-label pilot trial with 12 participants. So the average age was about 63 years old, with 5 participants being women. Their treatment combined psilocybin at dose of 10 and 20 milligrams with psychotherapy. There was no serious advance report, and this is really important in this population because it's a population which can be sensibilized to side effects of long-term dopamine therapy with, of course, the occurrence of psychotic symptoms. However, 10 participants did experience some treatment-emergent side effects, including anxiety, nausea, and increased blood pressure. So looking ahead, there are several important paths we still need to explore, of course. First, we need maybe to continue the case series where participation of some patients who are willing to go to psychedelic-assisted therapy, open label trial, then to assess the tolerability of why not psilocybin and schizophrenia spectrum disorders. Also the question of maybe using microdosing in this population. Another viable option could be also the use of non-hallucinogenic LSD analogs. However, we are still at the infancy of such substances. And finally, well, maybe test also other serotonergic psychedelic with smaller half-life, such as DMT. DMT, which is also very particular because it really doesn't interact with dopamine. Dopamine pathway will put at risk at least a proportion of our patients. So, voila, thank you for your attention. Don't hesitate if you have any question, and I'm gonna give my colleague to continue the presentations.
Thank you so much. That was very interesting. We already have some questions in the chat, but we're gonna wait till the end of our session. So really, thank you again. I can't wait to hear a bit more about your research. Our next speaker is Professor Marta Bosia, and she is Associate Professor in Psychiatry, and she's also a clinical psychiatrist at the Schizophrenia Research and Clinical Unit of the San Raffaele Institute in Milan. Her research is mainly focused on chronicity-related issues in schizophrenia, including its comorbidities, which can be cognitive, social-cognitive, and as well as dysfunctions. So I'm interested in the development of assessment tools and how to structure rehabilitative interventions. So really, addressing novel therapeutic avenues, she has also looked into the potential of psychedelics. And this is why today she's going to talk to us about microdosing psychedelics to address the unmet needs in deficit schizophrenia. Thank you very much.
Thank you, Georgia. Just a second. Okay, so can you see the slide? Yes, okay. So welcome to everyone, and thank you for joining, and a special thank to the organizing committee and to our chairs. This evening, in this presentation done at four hands with Jacopo Sapienza and linked to the previous presentation of Dr. Sabet, I will fill the dots from all the clinical studies to new preclinical evidence that lead to a possible treatment protocol proposal to use psychedelics in schizophrenia. Before starting, I have nothing to disclose, and while I have contributes to acknowledge. And first of all, I would like to thank all the team, the multidisciplinary team at the Schizophrenia Research and Clinical Unit where I work in this beautiful context of a previous private mental health asylum in Milan, as well as our neuropharmacologist Danilo De Gregorio and the team of Valentina Bambini at USP Pavia for the part of effects of psychedelics on language. Psychedelic state and schizophrenia shares several similarities as well as core differences. And we believe that main connections lie in connectivity. Connectivity, especially brain connectivity, but also within the language network. looking at brain connectivity in this paper which was published last year by Jacopo Sapienza. We highlighted and compared the disconnection state associated with schizophrenia with the hyperconnection state induced by psychedelics. And especially what we can see that they lead to similar phenotypical manifestation, however, through opposite mechanism, through specular mechanism. In schizophrenia, we have a disconnection in the connectome, which is related also to the increased synaptic pruning and a decreased expression of mTOR. While in the psychedelic state, we have similar symptoms, but the opposite is happening in the brain. We can observe a hyperconnection in the connectome, and among the mechanisms leading to this hyperconnection, we have an increased mTOR, leading to increased neurite growth and dendritic arborization. So there is a disorganized hyperconnection. Moving further, we are starting to look at the relationship between psychedelics, brain connectivity, and language. And we are doing it through a systematic review that Jacopo is preparing. What we observe is a dose-dependent pattern where at microdoses, who do not significantly affect the connectivity, we have some improvement in linguistic features, while at macro doses linked to the hyperconnectivity state, we can see the presence of deficit in speech production. And I would like to notice that this alteration that we see in linguistic features after administration of psychedelics, in this case in healthy volunteers, are the same as the core linguistic deficit that we see in people with schizophrenia. We have a disorganization of discourse, and we also have a reduced verbal fluency, which is common, especially in negative symptom in schizophrenia. So, are psychedelics and schizophrenia possibly two sides of the same coin? And especially, can we use psychedelics to treat schizophrenia? As suggested also by Dr. Sabet, our answer, and not only our answer, but it is an answer that it is shared between the scientific community, is yes. And we discussed this topic, highlighting the potential risks and benefit in this perspective article, in this review article published this year. We do believe that there are evidence, strong evidence, suggesting that the benefits may overweigh the potential risk. This evidence is based on a strong rationale with different hypotheses on the mechanism of action, because the beneficial effects of psychedelic treatment for psychosis relies probably on the interplay between different mechanisms, including the increased connectivity by mTOR, which I mentioned before, but also the increased expression of TAR, which I will go on later, leading indirectly also to an increase of glutamate, but also on the anti-inflammatory properties of psychedelics, knowing the negative effect of neuroinflammation in schizophrenia and especially on cognitive deficit. Moreover, what we expect is not only a clinical improvement in some symptoms domain, which, as you may guess from the picture here, are mainly expected in the social interaction domain, but also an ability to possibly restore the functional abnormalities that we see in brain in schizophrenia. So what are all the studies telling us, as more systematically summarized by Dr. Sabet? These studies suggest efficacy. Those are studies dating back to the 40s and up to the early 70s of the previous century. And looking at efficacy, we can see benefits, especially in social interaction, in affectivity, even in social cognition, because we have reports of a better understanding of social situation and more appropriate reaction to social situation. But not only, also we observed less, they observed less stereotype and rhythmic behaviors. So other features that are considered more core psychotic symptoms. Concerning safety, as highlighted, one aspect which may be counterintuitive is that the truth is that even higher doses are required to induce psychomimetic effects in people with schizophrenia compared to healthy subjects. So this evidence seems to go against the idea that they are more risky. Of course, we have to consider also the role of the dose and the phase of illness. If we consider the ultra-high-risk population, as mentioned by Dr. Sabet, or if we consider people in the acute state, then the risk is high. But for the chronic residual phase, the risk seems to be even lower from the spurious evidence that we have than in health controls. This old evidence linked to a novel biological rationale, and there are many evidence of the biological rationale. I would like to point out specifically to two aspects. One is the triamine receptor system, which is activated by psychedelics, and it is increased in schizophrenia, probably as a compensatory mechanism. That TAR1 in the mouse model increases the activity, the perfusion in the prefrontal cortex, and reverts the so-called cognitive deficit, for what we can measure in mice. Similarly, the use of TAR1 agonist in schizophrenia showed evidence to decrease negative symptoms. Also, looking at neurophysiological correlates, studies on healthy volunteers showed that psychedelics microdoses modulate the critical EEG indexes, such as alpha, theta, and delta power. And interestingly, the same indexes that are modulated by psychedelics are associated with the severity of negative and cognitive symptoms in people with schizophrenia. So, psychedelics and schizophrenia share differences and similarities, and we can capitalize on the differences to propose a treatment protocol. A treatment protocol, we believe, is needed because it addresses unmet symptom dimension. Schizophrenia is indeed the 8th leading cause of disability worldwide. And the main contributors of such disabilities are cognitive and negative symptoms, present in over 80% of patients and refractory to all currently licensed medication. So, the evidence converge on the promising role of approaching microdosing of psychedelics to treat these symptoms, but they are still hindered by safety concern. As a possible treatment protocol, we see as the main goal to test the efficacy on negative and cognitive symptoms, which are the core features that are refractory to current treatment, and also the domains for which there is a more solid rationale of use of psychedelics. And as a secondary aim, it would be interesting also to test the enhancing effect of combined rehabilitative strategies, such as similarly to the psychedelic-assisted psychotherapy. We can think of a psychedelic-assisted cognitive rehabilitation in schizophrenia. And also to clarify and better understand the biomolecular and neurophysiological correlates of the improvement that we expect to see in negative and cognitive symptoms. In order to do so, we believe that a good population to start would be those of the population of patients with schizophrenia, and more specifically with the so-called deficit syndrome, affecting almost half of patients with schizophrenia. So we need to select a population based on the positive and negative symptom severity, with high negative symptom severity, with the presence of cognitive deficit, and with stable and low severity of positive symptoms. We can think of a treatment protocol using especially psilocybin, which today it seems the safer choice, because it is the psychedelic for which we have more safety data, and it is more widely used. At low doses, around 2.5 milligram for twice a week, and leaving, of course, the concomitant antipsychotic treatment, and possibly adding rehabilitative strategies, especially cognitive remediation technique. And for safety, we may consider a brief hospitalization of the patient at the beginning of treatment, and a careful monitoring with positive and negative symptom scale for the initial phase of treatment. As outcome, we expect the main outcome to be on negative symptoms and on cognitive deficit, but also to extend to social cognition, communication, and daily functioning. And possibly to see an effect, to be able to restore the hypofrontality associated with schizophrenia, as well as to induce a cascade promoting brain plasticity. Finally, to conclude, some ethical consideration. Again, as I said, we believe that this possibility of treatment is worth, because this subsample of patients burdened by severe cognitive and negative symptoms experience often functional disability and poor quality of life. This is a severe condition. There is no valid therapeutic option, and for this reason, the potential benefit, in our opinion, clearly overweights the low risk of worsening of positive symptoms. Another aspect to consider is the shared decision making, which should be to which we should pay special attention. And finally, we can imagine to consider the possibility to include a caregiver or partner of the study to help and support the patient in his or her decision, and especially along the course of study. And I thank you for your attention, and here you find the email address, mine and of Jacopo, to write us if you have questions. Thank you.
So thank you once again. It was really beautiful to see how you could weave the preclinical and neuroscientific data into then a clinical perspective. I think that's extremely fascinating. And we'll see about the perspective of using microdose to treat negative symptoms. So thank you again, absolutely. For moving swiftly on to our next speaker, who is Jade Gallo, and she's a master's graduate from the Teachers College at Columbia University, and she currently works as a research assistant in the lab for culture and mental health disparities under the supervision of Dr. Monica Williams at the University of Ottawa. And they focus on disparities in psychedelic research. So they also have interest for the treatment of psychosis and disparities in mental health more generally. So she also has experience working with multiple psychedelic-assisted therapy centers to help facilitate operations, develop new protocols, and manage clientele. Today, she will be talking to us about experiences of psychedelic drug use amongst people with psychotic symptoms and disorders, and about how we need more data from naturalistic use. Up to you, Jade.
Hi, everyone. Thank you. And I will be getting some help with sharing my slides today because I was having some technical difficulties. So let me know if, okay, looks all good. So yeah, my name is Jade Gallo, and thank you so much for that great introduction, Georgia. I also wanted to mention that I do work alongside Dr. Joseph Latore, who will be presenting after me. He's at the University of Washington, and our research team with him and I conducted a study that explored the reported psychedelic experiences of individuals with psychotic type disorders and psychotic symptoms. And just a few notes before we move forward. We further break down our definition for psychotic type disorders here. So PSD, you'll see it'll be relating to psychotic spectrum disorders. Psychotic mood disorders will be labeled as PMD. Psychotic personality disorders will be labeled as PPD. Other psychotic disorders and unspecified psychotic disorders will be labeled as OPD and UPD as well. And for the definition of psychosis, we're referring to psychopathological experiences of psychosis. And our paper is published, so here is a little screenshot if you'd like to go find it and read it for yourself. So just to highlight the reason we're interested in this topic, it's because there is a historical narrative that people with psychosis can't take psychedelics, or there's going to be this fear that it would exacerbate symptoms or even cause latent schizophrenia to develop in people who have a predisposition to these kinds of conditions. While these fears may be valid, there is still very limited research that actually does support these claims. And there have been instances where some people with major depression disorder, for example, with psychotic features, have been included in some studies. But again, there hasn't been any studies where the focus of the research is on how this population specifically responds to psychedelic-assisted psychotherapy. So that leads to the main question of why, and our goal is to help develop data-informed empirical clinical decisions and rationale. So even some indigenous populations I'd like to highlight include this group in their plant medicine practices, but in Western medicine, we tend to not. So I also want to emphasize that the why is not actively being researched, which could cause barriers to those looking for alternative treatment methods. And this strict exclusionary criteria widens disparities in mental health care, specifically disproportionately affecting BIPOC communities who are often over and misdiagnosed with psychotic disorders. And this is a real example of one of the exclusionary criteria from Johns Hopkins and many other clinical trials, but they specifically list that a first or second degree relative with schizophrenia spectrum or other psychotic disorders and bipolar 1 or 2 disorders cannot be included in their trials. So the person themselves might not even be diagnosed, but if you have a relative, you're excluded from these types of research. And looking back to see where these exclusions came from, the first wave of psychedelic research from the 1940s to the 1960s provided initial insights, but it was also marred by ethical issues and inhumane experimentation, particularly among marginalized groups. Diagnostic practices were at this time imprecise, and many findings have been questioned. So additionally, the cultural backlash during the LSD crisis of the 60s further stigmatized psychedelic research, contributing to the enduring misconceptions about these substances as strictly psychotomimetic. And yet, we have seen some modern research that is being conducted, particularly within the past year or so, especially within the past year or so, I should say. And these are just some new examples that I'd like to highlight that also, kind of inspired us for this research. And then our team also wanted to address concerns stemming from the first wave of psychedelic research. So here's the citation again. And for our research question, we sought to collect data to determine this idea of psychedelic-induced psychosis or symptom worsening, and see if it really does happen and what it looks like, how frequently does it happen. We also wanted broad data. Do people also report good psychedelic experiences, and what could that look like? So these are some of our key research questions, and we sought to capture all of this in our survey, which was a cross-sectional, retrospective, mixed method survey where we asked people to think of one specific moment in time where they took a psychedelic and to tell us about their experience. They had to also have passed a large screening criteria, which was included, and that included their diagnosis, their age, what psychedelic they took. And they also had informed consent provided. And if they followed all of the criteria, they were prompted to complete the survey. So a brief study overview, we conducted this online survey using mainly platforms like Reddit and other social media platforms to recruit participants who have had experienced at least one psychedelic experience and are either diagnosed with a psychotic disorder or experience psychotic symptoms. This survey collected detailed information on demographics, mental health history, specifics on the psychedelic experience like drug type, dosage, and context. And it included standardized measures like the MEQ30, which we later refined to an 11-item version for analysis. And we were also really interested in qualitative data, so we included multiple sections for qualitative responses. And our analysis followed a rigorous qualitative process, again, involving data familiarization, initial coding, theme development and analysis, and collaborative review with the research team. And so our participant demographics consisted of individuals with a range of diagnoses. About 40% of the population had psychotic spectrum disorders, PSD. 35% were diagnosed with PMD, 15% reported PPD, and 15% of the sample reported other or unspecified conditions. Additionally, 98% of the participants reported having delusions, 70% reported hallucinations, 80% reported negative symptoms, and 5% reported other. The average age was around 28.5 years old, and our sample was pretty diverse in terms of gender and sexual orientation. but not race, which could be due to Reddit's overall demographics, as that was our main recruitment source. So the stats for the psychedelic use, the most commonly used substance were psilocybin mushrooms at 43% and LSD at 38%, and lesser used substances that were reported were ketamine, MDMA, DMT, and ayahuasca. So for our outcomes, a significant majority, the 88% overall, reported experiencing some degree of personal growth. And we also saw users of both LSD and psilocybin reporting high rates of personal growth as well. And here we have our MEQ scores, which I said we refined to the MEQ 11. Each item was reported to was rated out of 10, and 58 people out of the 100 sample completed all of the questions. So 84% of the people scored higher than the sum of an average of 5. And 34% scored higher than the average of 8, and 16% scored higher than an average of 9, showing that the MEQ results were pretty strong. A lot of people reported mystical experiences, especially for the average of those who used psilocybin and LSD, who also answered the MEQ. Those average scores were about a 7. And additionally, many participants experienced enhanced spirituality, a better understanding of personal history, increased feelings of love and appreciation, and improved resilience. But for the sake of time, I won't go into all the specific percentages. And these are some exemplar qualitative examples from participants to back up these findings. So these were for improving symptoms, and participant 1 reported reduced paranoia, and they used psilocybin and had schizophrenia. Participant 5 reported having an overall positive experience and had reported using psilocybin combined with marijuana and had a diagnosis of bipolar. Participant 11 reported a surprising recovery on ketamine and had experienced a first episode of psychosis. Participant 15 stated that psilocybin helped resolve difficult areas of their life, and they also reported having brief psychosis. And participant 16 reported saying psychedelics opened their heart and reduced fear, and said that they had schizophrenia as their diagnosis. So this quote really stood out, and I just wanted to share it with you all. Participant 16 said, "I feel like psychedelics open my heart and make me feel less alone. I'm not certain if it lessens my hallucinations, but it definitely makes them more bearable because it removes the fear and makes me feel more connected." And again, this person had taken ketamine, they were diagnosed with schizophrenia, and they reported being in a comfortable setting. So now on the worsening symptoms end of the spectrum, there were reports of negative outcomes that I also want to acknowledge. So participant 4 said LSD made their psychosis worse. Participant 6 said psilocybin plus marijuana combination was the worst mistake of their life. Participant 7, who took LSD, said it was a giant 15-hour bad trip. Participant 10 said LSD and alcohol impaired their thinking ability. And participant 12 said LSD and marijuana was a necessary trauma that they experienced. But again, participants 10 and 12 had combined with some other substances that could have potentially contributed. Participant 4, like I said, they had taken LSD, the alcohol mixed with nicotine and marijuana as well. They had a diagnosis of schizophrenia, and they were in an uncomfortable setting, as they reported. They said it was awful, and it made their psychosis much, much worse. So emerging expert opinions now suggest that when administered under carefully controlled protocols, psychedelics might not only be safe for some individuals with psychosis, but could potentially offer therapeutic benefits. So it's important to note that about 11% of users in our study have reported negative experiences of psychedelics. And our findings also suggest that psychedelic use in individuals with psychotic experiences can lead to meaningful personal growth, and in some cases, even symptom relief. However, these outcomes are highly dependent on variables such as drug type, dosage, notably set and setting in which the experience occurs, and other confounding variables that can definitely affect the overall experience. So what does this mean? Is this historical narrative rooted in truth, in data, or perhaps fear and an unethical level of research that was done? We would like to root in truth now, however, that this study, we found this population can potentially benefit from psychedelics and report some degree of personal growth. Many participants did have profound experiences, mystical experiences. Some gained insight into their disorders and symptoms, and we really believe that this shows promise and is worth exploring further. We would even potentially like to take this a step further and maybe do a clinical trial where we plan to administer psilocybin or another molecule as the protocol is still being developed. But the goal is to develop a psychedelic-assisted psychotherapy protocol for this group as eligible candidates. I do want to emphasize that we believe this treatment could benefit some people, not all with psychosis, but we do believe there is promise, and the research underscores the need to re-examine this blanket exclusionary criteria that was developed, and further research is needed to pursue, safely explore therapeutic protocols for this population. Moving forward, more rigorous, inclusive, and controlled research is essential to fully understand the potential benefits and risks of psychedelic therapy for all, and especially for individuals with psychosis. And these are my references. And yeah, thank you. Looking forward to any questions.
Thank you so much, Jade. Also, I can't wait for the clinical trials, and thank you for the beautiful slides and for your rigorous work. So thank you for also portraying the good and the ugly, which I think is fair enough. And last but definitely not least, I think we have the powerhouse that is Joseph Latorre. He has a long resume. He is the lead research psychologist at the Center for Novel Therapeutics in Addiction Psychiatry at the University of Washington, where he co-leads psychedelic clinical research, including a 3-year phase 2 psilocybin safety clinical trial, which is funded by the state of Washington. He is also clinical advisor and lead educator at the Oregon Psychedelic Institute. Additionally, he is an instructor in the School of Psychology at the University of Ottawa, where he teaches courses on psychedelic therapy and traditional uses of psychedelics in the Master of Arts and Psychedelic and Consciousness Studies, which seems like something that I would personally love to do. And of course, he's a member of the Scientific Advisory Board for our Italian society, Synapsy. And today he's gonna close our session with his talk about psychedelic-assisted psychotherapy for psychosis spectrum conditions and how to translate preclinical insight into clinical trial design. Thank you so much.
Thank you, Georgia. Okay, I'm gonna share my screen here, folks. That look okay? Yeah. Okay. Hi, everyone. Buonasera. So, yeah, I'm gonna be talking about translating preclinical insights into clinical research, the promise of PAT for treating psychotic disorders and symptoms. Oops. So these are some of my affiliations. Georgia already went over them. I don't have any conflicts of interest for this particular presentation. So this has already been touched on, but it's important to mention that people with psychosis have been long excluded from psychedelic therapy and psychedelic research, and it is a blanket exclusion, a categorical exclusion in most cases. But I would argue that this is unfounded. And that actually evidence supports that a lot of folks in this population do report having positive and mystical experiences with psychedelics, though not everyone. And so this presentation, I'm going to be talking mainly about the study that Jade just presented on, as well as another study where we asked 12 experts in the field of psychedelics and psychiatry about the potential use of PAT for this population. So where does this leave us? The takeaway from our studies, I would say, is that we are ready to move forward carefully but deliberately with some clinical research. And a few of us are starting to do that, like Michelle and a few colleagues of mine in Canada, under special access programs and compassionate use. And I think that we should continue to do so. Three kind of key factors, I think, are at the center of this conversation. One being the individual and their individual background, their clinical profile. Number two would be the psychedelic medicine that we're using, because we have many in our toolkit. And then I would say number three would be a combination of the protocol and the study design. And so this is one study that I'm going to be drawing from for this talk, as well as this one that Jade just went over. So first, kind of talking about the individual here. I'd like to kind of take a step back. We've been talking about treating people with psychosis, but what is psychosis? What do we mean by that? And one of my mentors, Paul Groff, points out how old this term actually is. It's actually a very, I would say, outdated and antiquated term in the field, like also the term schizophrenia. And you know, psychosis, it isn't, psychosis itself is not a diagnosis. It's a heterogeneous spectrum of experiences, and it can involve anything from perceptual, cognitive, emotional, and existential disruptions and disturbances. And some folks have mild symptoms, some folks have more impairing and dysfunctional symptoms. And I would also say that the range of causes is diverse. You know, in mental health, we say that disorders are the result of biopsychosocial origins, and you know, I think that's really important to bear in mind in this conversation, because there has been in the past a lot of conversation that psychosis and schizophrenia are brain-based diseases, and I'm of the opinion that that the literature really does indicate a very strong trauma component to psychosis as well, and I'm going to touch on that in a couple slides. But yeah, going back to the individual profile, there's a wide range of possible symptoms people can have, including negative symptoms versus positive symptoms, delusions, hallucinations, and someone could have just some hallucinations that don't even cause distress really. And then on the other side of the spectrum, you could have someone who is, you know, really severely impaired and has all of the possible symptoms. And then at the same time, there's also a range in severity. So folks could have, very severe symptoms, or more insight versus no insight at all. And for early clinical research, I'm gonna suggest including folks who are on the lower end of the severity and less symptoms, less severe, and then we could start working our way kind of up the ladder. And then in terms of the pathogenesis, there, as I mentioned, there's a wide range in terms of the origins of this disorder and this populations. But I will also stress that there is a biopsychosocial origin for any disorder, I would argue. And in particular, the data do suggest very strongly a correlation between trauma and psychosis, and that individuals with psychotic disorders are 3 times more likely to have experienced childhood adversity. There's a dose-response relationship that's been found. The more trauma that's been experienced, the more severe the psychosis symptoms. And I mean, anecdotal evidence too. If you ask around people who treat people with psychosis, they tend to see that psychosis can often act as a defense mechanism and a way to detach from a painful reality and recreate a more creative narrative that is less painful but not based in reality. And there would be many questions to ask in choosing the right candidate for some early clinical research, exploring PAT for this population. Are they actively psychotic? I wouldn't recommend including someone who's in an active state of psychosis, at least in early research. Have they harmed themselves or others in the past? Do they have a history of trauma? Are there other disorders co-occurring? What level of insight do they have? Are they capable of forming a relationship with the therapists? Do they have strong support outside of therapy? Are they on medication? Should we taper them? Would they interact with the drug that we're giving them? And maybe even most importantly, are they eager to get better? Are they motivated to get better? And then so moving into the medicines, there's many available to us, but referencing some of the data in our preclinical survey study, the most commonly reported substance was psilocybin, and there were a lot of really positive reports with psilocybin, and compared to the LSD, there were more positive outcomes. And so, for example, this person said it was eye-opening, much different than LSD. LSD made them panic, got lost in time. With psilocybin, they felt more mellow. It was less intense, less overwhelming. It was insightful and beautiful. And this person reported having a first episode psychosis diagnosis. And unfortunately, I don't know whether that happened before or after the psilocybin, but I'm not sure how important that is actually. And then, the vast majority, 92% of the people in our study who used psilocybin reported personal growth and strong, powerful mystical experiences. And insight, several reported symptomatic improvements. It was also a theme that sometimes people didn't experience that their symptoms went away, but that the psychedelic experience changed their relationship with their symptoms. So that was like one of the quotes that Jade shared. It wasn't that they made the delusions go away, or hallucinations, it changed their relationship with them. And then there were some folks in our expert study that said that in their experience, psilocybin might reactivate trauma for some folks in this population, which I thought was interesting. And if we were to give psilocybin therapy to some folks in this population, that we should really integrate very robust preparation sessions, skilled integration, and a lot of support. And that maybe this would be suitable for folks with mild to moderate symptoms, at least some insight, and maybe their psychosis is centered around some existential themes. Then the possibility of using LSD for this population. Again, this was the second most frequently used drug in our sample. A lot of people did report that their experience resulted in personal growth. Even if it was challenging, sometimes it resulted in personal growth, and that's common to see with psychedelics. However, this one individual said, for example, it was too high of a dose, and that they had better experiences with psilocybin. And so, keeping that in mind, LSD is very, very potent. And then, there were quite a few negative outcomes linked to LSD. And I don't know if you noticed the trend when Jade presented the data that most people who reported worsening symptoms used LSD. However, there were numerous confounding variables. So a lot of them also mixed the LSD with something else or used it in a setting that they weren't comfortable in. So we're not really sure if that had to, we can't assign causality to the fact that it was LSD. However, knowing the phenomenology of LSD and knowing that it can cause things like thought loops and confusing thoughts. It seems to be less kind of emotionally grounding compared to psilocybin. So I would suggest that might not be my first choice for a clinical study. Compared to MDMA, that was much less commonly reported in our naturalistic survey, but it was the main drug of choice in our expert survey. Most of these experts said that it would be their first choice, the MDMA. And one person did say in our study that I understood a big part of my psychosis was due to traumatic experiences. And they used LSD and MDMA, and I don't think they had a diagnosis officially, but they did report having hallucinations and delusions. And so, MDMA, we have the data that shows it's a pretty effective tool in the therapeutic and controlled setting for treating PTSD. And if there are traumatic elements to people's psychosis, I would assume that it could be helpful for that group as well, knowing that MDMA enhances empathy, fosters a safety, feelings of safety, and promotes traumatic processing. It might not be recommended for folks with manic psychosis, since it does have strong stimulant properties, but I would suggest that we start here personally. Another potential candidate would be ketamine, and one person said that the ketamine got them out of their psychosis. So, I mean, it even sounds like they were in an active psychotic episode and the ketamine helped them get out of it, which I think is fascinating. The experts did say that it's probably less likely to trigger a psychotic episode. We know ketamine phenomenologically doesn't induce these profound visuals. I would say it does. It says here it doesn't induce strong mystical effects. I think it does, but it can also promote this kind of sensation of spaciousness and detachment and relief. And I think that would be good potentially for some folks with kind of rigid patterns, rigid thinking like delusions. And there were a couple studies that were done here at the bottom where ketamine was given to some people who had both depression and psychotic symptoms. And they found that the ketamine did not worsen the psychosis and reduce the depressive symptoms. That's not the same as saying that it improved their psychosis, but it is a start and is promising. And then just a brief overview is that these psychedelics, you know, everyone did report at least some degree of personal growth, or, you know, some people using these drugs did report personal growth, and that we'd still need to do some statistical analyses. Actually, we're doing that with the data right now to verify our findings. And I'll also say that even though I do think it's time to move forward with more clinical research, we can always still keep gathering some naturalistic research, so data, because we didn't capture data about use with DMT as much, or ayahuasca, mescaline, even ibogaine, or other empathogens. And then moving into protocol and study design, I think that, you know, this would have to be a layered approach. Like I've been saying, I think we need to start off small and gentle and lower dose, more stable groups, more mild symptoms, less severe cases, really emphasizing preparation and integration, maybe even having an inpatient protocol at first, and keeping folks under monitoring them around the clock for a few days, or even as long as a week or longer. You know, I think something that is worth pointing out is that the current protocols for, you know, MDMA and PTSD, or psilocybin and depression, those protocols probably don't offer enough support for this population. So I think that we do need to emphasize stronger support systems. And eventually, you know, right now for early trials, I would exclude people with, you know, past suicide attempts. But I do think that eventually, if we start to see promising results, we should test that population as well. And we should have crisis protocols as well, medication rescue plans. And I think what we're doing right now with the special access programs, what Michelle is doing, and others, I think is the right way to go about it. N of 1 studies, and also looking at different presentations. Right now, there is a phase 1 study at UCLA looking at the tolerability of MDMA for schizophrenia. And I think that we will eventually need to do those kinds of studies with every medication. And you know, right now they're doing MDMA for negative symptoms. I think we're going to need to then do for positive symptoms, and then psilocybin for a safety study of psilocybin for negative symptoms, and go on building it that way. And then phase 2, and then eventually phase 3. And that will be much further down the road, hopefully in my lifetime, but we will see. And I'm almost at the end here, but just emphasizing the need for a tailored approach, and also really emphasizing the different profiles of the psychedelics, because it is such a diverse area with all these different medicines that seem to have very distinct and unique phenomenological profiles, and distinct therapeutic mechanisms that could be beneficial to different presentations. And so in summary, you know, psychosis is very heterogeneous. We have some preliminary naturalistic data that would suggest that it shows rather unequivocally that there are many people with psychotic backgrounds that benefit from psychedelics, as well as a small minority that have had very negative experiences, but that seems to correlate to lack of preparation and lack of intentional use and improper setting. And that ultimately, I believe it's time to move beyond the kind of fear-based thinking that doesn't really have a lot of data to support a blanket exclusion, and that I think it's you know, time to move forward and be courageous and inclusive, and these folks deserve care as well. And so yeah, I think, you know, this webinar is doing just that. And so with that, I'll say thank you, and happy to answer any questions, and I'll give the mic back to Georgia. Thank you.
Thank you so much, Dr. Latorre, for such a rigorous and considerate and also thoughtful presentation, setting the bar quite high for the rest of us to continue this kind of research. I would like to open the space for some for a dialogue or a discussion, and before picking some questions from the Q&A space, I'd like to know if the speakers wanted to ask each other some questions.
Well, actually, there's one question in the chat which I could ask to Joseph. It's the last one from Gabriele Penazzi. In your opinion, should future clinical studies distinguish between early and treated psychosis and more advanced treatment-resistant forms such as chronic schizophrenia? Should ongoing antipsychotic treatment influence the accepted efficacy of psychedelic therapy? But I can also ask this question to Marta or Matteo, of course. Jay, anyone.
Should early research prioritize, it sounded like earlier forms of psychosis versus later developed? Is that the question?
Yeah.
It's a good question, because I mean, you know, we're not sure if someone who is kind of in the the earlier stages, we don't want to exacerbate or accelerate the development of latent psychotic disorder, and at the same time, you know, someone who my answer to that would be the folks who are in the earlier stages tend to be younger and adolescent, and so I would say we wouldn't want young adolescents and more of adults. So maybe further on, I would say, rather than early. That's just my opinion.
Yeah, it's like in our study, we found this 13% of risk of transiting from transition-induced psychosis to schizophrenia, and yeah, this is a problem at the end. No? Of course, it's lower than cannabis and methamphetamine, but 13% is still quite a big number. Maybe if you focus on chronic schizophrenia for a start, would make more sense.
Yeah, someone whose symptoms have already been developed and kind of stable, so we know what that person is like, I would say. Yeah.
Also, that probably correlates with what Michelle and Professor Bozia were saying about the negative symptoms. So especially if negative symptoms are more preponderant during the chronic phases, then that's probably where we should start. also given that the transient or initial phases are a bit more delicate, especially as the self structures around the psychosis. Maybe you don't want to add anything from the exterior, but that's just anecdotal, I guess.
Yeah, I agree. As said by Joseph, to start smooth and safe, the chronic phase would surely be the safer one to target. And related to this aspect, I have a question for Joseph. As you mentioned that possible exclusion, among possible exclusion criteria, patient with pronounced cognitive disorganization. And I'm ambivalent about that. There may be some pros and some cons, so I would like to comment on that.
Yeah, I think, my point is, when I would like for us to just be slow in our in starting this research. I don't want to just jump into the deep end, and I think that prioritizing people with, for example, maybe 1 or 2 symptomatic experiences, like just delusion, just some delusional thinking or some hallucinations but it's not very distressing, and start there, and then work our way up to more kind of severe delusions is all I'm saying. I think ultimately we need to test all of these presentations on the whole side of the spectrum. As scientists, we do need to test it, I think. So I'm just saying earlier on. But does that clarify what I was saying? Okay.
We have a few questions on the pharmacological treatments. One is from Marta from the chat, and she asks, how does all of this compare to antidepressants that are also often prescribed for negative symptoms? So in essence, what would be the upper hand in using a psychedelic rather than a classic antidepressant?
I can take this one, and this is true, clinically they are used, but one difference it's in the prosynaptogenic effects of psychedelics, which is not so for antidepressant. And it may be related to the specific serotoninergic receptors on which psychedelics may act, as psychedelics are lipophilic molecules. So they act also on intracellular receptor, and this intracellular serotonin receptors are the ones that are mainly associated to the synaptogenic effect, differently from the serotonin itself, which increases in the synaptic space through antidepressant, and differently also from antipsychotics. Most antipsychotics have some blockade effect on a serotoninergic receptor, but limited to the receptor expressed on the external surface of the cell. So this may be a key difference between current pharmacological treatment targeting the serotonin system and psychedelics. Not limited to, of course, there are also other, but this may be one key aspect.
Well, thank you. That was actually a brilliant answer, because as a phenomenologist myself, I was thinking a lot about the psychedelic experience, but of course, it's interesting because the neuroscientific aspect and the phenomenological experiential one do combine beautifully sometimes. Matteo, can you answer the one about talking about phenomenology.
Which one is that?
This is the hard question, but I really want to know, actually. To what extent does the phenomenology / symbols occurring thematics of a psychedelic-induced psychosis differ from an average psychedelic experience? So, are there some differences? Can you mention some qualitative aspects?
Well, please, Joseph, if you want to. Well.
Sorry, wait, just to clarify, is there a difference? Do we see a phenomenological difference? Is that the question?
The question, yeah, between a psychedelic-induced psychosis and an average psychedelic experience.
Well, there is this model that, oh, sorry, Joseph, please.
No, I was going to say, it's not what I thought the question was asking, please.
Well, there is this model that actually has roots in the Italian psychopathology that is named psychoma, that suggests that that substances-induced psychosis and psychedelics-induced psychosis differs somehow from endogenous psychosis, because they tend at the early stage to be like more an external object with which the subject has a sort of critique, and then that progressively, like a metastasis, like grows and disrupt the self of the subject and become a full-blown psychosis. So actually, this is described in classical psychopathology, and recently some author just repicked up this idea and explored this idea. We don't have too many data about it, but it's interesting to see the differences, at least at the early stages. So it is a very interesting question that I think merits more qualitative research into that.
Absolutely. Thank you so much. I think we should go back to pharmacology at this point. I think there's an interesting question, especially looking towards the structuring of clinical trial, which was asked by Gabriele Pennazzi. He says, given that antipsychotics are standard for treating psychosis, should they be discontinued before a psychedelic treatment? If so, what would be an appropriate washout period?
Well, I
think Michelle
a clear answer. In my opinion, they should not be discontinued to start up psychedelic protocol, because as Joseph said, let's go slow and smooth, and we do not want to discontinue, but to use it as an add-on. If that was the case, it should be probably a few weeks, but I don't see it being the case for now.
Yeah, I'm also working actually on dose reduction in patients with maintenance treatment, with antipsychotic maintenance treatment. And this is really a hard question, because at the end, if over a period of 6 months, some patients could reduce up to 30% of their medication. When we continue to reduce the medication, or sometimes try to stop the medication, there's a high risk of relapse, and most patients who have chronic schizophrenia. So at the end, maybe a first step would be to try to reduce a bit the medication, or if the patient continues to be stable, to switch to a third generation antipsychotic. Then maybe there's an underlying question: could a patient have psychedelic trip, given the fact that he's actually taking an antipsychotic? So this was also the question in our current report. Yes, it's possible with alloperidol, probably, but with alloperidol, you have some articles of Vollenweider from Zurich, who's now retired, who said that sometimes you can have also more side effects with substances. So he's very precautious of giving alloperidol to patients who are trying to use psychedelics. For amisulpride, our patient was on a nil dose of, I don't remember, 400 milligram, right? So it really covers positive symptoms, in particular the one which could pass by the dopamine pathways. And then I also have some of my patients who told me that they had brexpiprazole. So it's like Abilify, it's a third generation antipsychotic, and they did experience some psychedelic trips while taking their medication and LSD or other substances. So at the end, yeah, it's the big question. Is the psychedelic trip essential to the antidepressant effect? Is it essential to reduce negative symptoms? It is essential for the patient who wants to experience something else. This is really an open question. We have some ongoing trials to try to respond to this question, but we don't have results yet. But apparently, from some case report and some hearings of patients, it's possible to have a long-lasting antidepressant effect, although the effect size might not be as high, as important as when really experiencing a psychedelic trip.
Thank you so much. Hopefully we'll know a bit more about that in the future, and then we'll know what kind of antipsychotic is the best to be coupled with the psychedelic experience within the trials. And yeah, amisulpride seems to be possibly a good option, so you can have the free dopamine and then still have the action of the serotonergic. I have a question, I think, for Jade. So Georgia asks, do we have any hypothesis on why some patients live the negative trip or so their symptoms worsen? Any recurrent theme that can be identified?
Yeah. So we hypothesized that a lot of the negative experiences that were due to potential confounding variables that they also reported. So like, they reported either being in a negative setting with people that they weren't comfortable with. Some people took too high of a dose of the psychedelic that they had taken. There, like Joe had said before, we did see a lot of people who had taken LSD report negative experiences more often than other psychedelics, but also there were a lot of people who took LSD plus another substance. So that was also something we wanted to look into. There's a lot of factors that we didn't have any clear cases like this person took LSD, they were diagnosed with schizophrenia, they were in a comfortable setting and like had all of the good boxes checked off, and then they had a negative experience. There was always some nuance to why people had a negative experience or saw their symptoms worsen. We also, some people did report potentially being on antipsychotics before taking the psychedelic, so that could have been a reason, or not just antipsychotics, but other psychopharmaceutical medications. There were a lot of different things that we thought could play into effect of the negative trips, but we wanted to look into it further. And given the data that we had, since it was all anonymous, we couldn't do a follow-up survey and kind of say, hey, why did you have this negative experience, or did something stick out to you that made you feel that way? But I would say a lot of the themes were either taking more than one substance, taking too high of a substance. Someone reported being in an active psychosis while they took it, and they hoped that the psychedelic would make it better. That probably would be something that can worsen your symptoms. Yeah, am I missing anything, Joe, that you think?
No, yeah, I think that's the answer is it's kind of impossible to know because it's not an experimental design, and there are many variables that we can't determine it, but there does seem to be a correlation. We need to do a statistical test though to verify that.
Thank you so much. It was quite a complex question to answer, but definitely worth looking into. I think we're coming towards some kind of closure. However, I did want to ask maybe one or two more questions. Sorry. There's a question by Lucy in the chat, and she says, do you think that testing typically used in cases of psychosis could also be applied to explore how psychedelics might support individuals with personality disorders? So we haven't talked much about that, but could you possibly comment on it? So the use of psychedelics for personality disorders and how the testing and assessments that were applied in the cases of psychosis could be translated to those.
I think that we do see a couple pretty common themes with people with personality disorders and psychotic disorders. You know, for one, they both tend to have low insight. They're also what we would call ego syntonic disorders, which mean they there's often some kind of identity with the symptoms, that it's not distressing in the same way that OCD is distressing. So yeah, I think that we could form some hypotheses based off of some research with this population that could inform people with personality disorders, especially psychotic personality disorders. Yeah, good question. Thank you.
Thank you so much. I think until now, so much of the research has been done on treatment-resistant depression and anxiety and PTSD that some other major psychiatric conditions have been just more or less completely blocked out. And so why not? One could inform the other. And I don't know, I'd like to leave the word to Matteo, maybe for a few concluding remarks, because quite late and I'm quite hungry. So
Okay, thanks, Georgia. Well, I would like to conclude just by sincerely thanks all the speakers for their outstanding presentations, or our supporters, or the audience, of course. I'm convinced that the talk we have today represents important step, little important step in advancing research in the field of psychedelic therapies, of course, for psychiatric disorders and for severe mental illness especially. Now, I want to emphasize, of course, that today's event is purely educational, should not be interpreted as an encouragement to use illicit substances, which can be extremely dangerous outside of controlled clinical settings and with the guidance of a specialist. And at the same time, we encourage anyone working in the research field or related fields to contact us if they believe they can contribute to the development of this highly pioneering area, which is, as mentioned in the introduction, I think of crucial importance for the clinical practice of psychedelic treatments in psychiatric conditions. So thank you all for your participation, and I look forward to continuing this important dialogue. Thank you.